Hello, my name is Dr. Carla Pridden. I'm a pediatric emergency medicine attending and the medical director of the simulation program at Connecticut Children's. During my time in simulation, which started back in 2011, I've had the opportunity to work with multiple interprofessional groups, designing simulation educational content based on procedural practice and deliberate training, all the way through systems integration and clinical design testing. As a disclaimer, all images throughout the presentation are royalty-free from clipart, Pixabay, or permission given by the organization. We are now transitioning from the simulation educator's personal focus in Domain 1 to the educator's process of developing simulation into courses. Many of these concepts will be covered in multiple domains, but focus on a different aspect of simulation education. As you know from the exam blueprint, this domain is 28% of the certification exam. These slides are based on the content contained throughout Domain 2. We've covered all the standards, though they are in a different order from the actual blueprint. This domain has a primary emphasis on the development and embedding of simulation into curricula, with attention on behavior change to improve patient safety. The purpose of simulation-based education. The ultimate goal of healthcare education is improving patient safety and patient outcomes. But how do we get there? Simulation-based educational sessions, or SBEs, can be designed for the individual, the team, or the system. Creating events for individuals means that objectives are geared toward individual-based learning needs or specific job requirements, such as annual skills validation or deliberate practice for procedural training, for example. Scenarios directed at teams speak to the performance of multiple team members coordinating care for a shared goal. Effective communication and organization of tasks or complex ideas and interventions are factors that define high-functioning teams. One example would be simulation creating the opportunity to practice hemorrhage response by allowing teams from blood bank, PACU, and anesthesia to train together. Applying simulation at the system level can evaluate and improve patient outcomes throughout an organization. As part of the design of a systems-level in situ event, to assess a new hypertensive crisis standing order set, for example, workflow engineers, as well as direct care partners and leaders, would all be expected to participate in order to appraise teammate understanding and ease of implementation after staff education is completed. It is important to think of the different logistical needs for each of these simulation applications. These would include equipment considerations, such as task trainers, ultrasound simulators, and access to the EHR training platform, as well as staffing resources, like time to accommodate sim ops specialists and educator meetings, with facility leadership for in situ events, as well as content experts for each profession that will be participating. Simulation educators are expected to weave together these concepts, addressing the learner level, objectives, and the correct simulation modality, with the environment, available resources, and safety to plan for specific user groups. Simulation has great potential to be integrated across many aspects of education, practice, and research, with techniques that can be applied to all levels in health professions education, from novices to postgraduate specialties. Simulation can be integrated to support multiple participant types, from pre-licensure undergraduate students to high-functioning multidisciplinary teams working at the bedside. Techniques can be applied across multiple aspects of the care continuum, from evaluating newly planned spaces to assessing recently implemented high-stakes processes or workflow changes. They can also be used to support various initiatives, such as just-in-time in situ education. These examples reinforce the relationship between quality improvement and simulation-based education. Simulation can be used either as a subject of research or as the platform for research. In recent years, for example, research around all aspects of virtual simulation has exploded to address questions like, is it effective? How does it compare to in-person simulation? And are learning outcomes being met? Simulation training can be measured to answer questions like, did we decrease time to first shock with a simulation-based training program? Seminal work in this area is from Jeffrey Barsuck and the team at Northwestern University, who looked at whether or not a central line training program for residents decreased central line associated bloodstream infection rates. Simulation is also well suited for research where the inclusion of human subjects would be questionable. For example, a research study that looked at 2-finger versus 2 thumbs for neonatal chest compressions. Resources for simulation-based education. As an educator begins to create curricula, they need to understand what resources are available and how they can be utilized to support simulation-based education. Being familiar with the different modalities that are available helps to allow an educator to choose the best fit for each SBE. Partial task trainers are the most common type of simulation tool used today. These simulators represent one body part or structure. They're great for working on a specific skill, but they can rarely be used as a standalone teaching method. Mannequins come in varying ranges of fidelity. Keep in mind that the term fidelity in simulation has evolved to describe the whole concept of the educational experience. When the term was originally used in healthcare simulation, it was to describe the human patient simulator features. In this section, we use the word to differentiate between categories of mannequins and the feedback they're able to provide to learners. Low technology mannequins or simulators allow for the practice of psychomotor skills. They're less expensive, but they lack realism, and they're difficult to use for the demonstration of interpersonal skills. Moderate technology simulators offer breath sounds, heart sounds, and a pulse, which allows for better understanding of some complex subject matter. They don't often have enough realism for complicated physiologic conditions, however. High technology simulators have an increased level of realism and can respond physiologically to learner interventions. They're generally more expensive, though, and harder to maintain. Standardized patients can be trained to portray a range of cases and can provide meaningful, individualized feedback. SPs have to be recruited, oriented, educated, and scheduled, however. Policies will also have to be created to ensure reliability and validity regarding SP performances. While virtual simulation environments have been around for years, the pandemic caused a surge in use across all learner demographics. These are usually immersive environments that can be used after hours or at home, but they can also include surgical, laparoscopic, and endoscopy trainers with haptic feedback that allows for the safe practice of complex skills. These have varying degrees of realism, however, and maintenance and access, including potential IT or manufacturer support needs, are always a concern with virtual reality. Another virtual simulation approach is the use of pre-recorded scenarios, where simulation staff record a planned scenario and share it via digital meeting platforms. Most virtual experiences can test individual skills, knowledge, and critical thinking, and they can assist with prioritization, a team-based element, though they may not be able to allow for customization with local policies and procedures. Augmented reality is a form of virtual reality that includes head-mounted displays, overlays of computer screens, wearable computers, or displays projected onto humans and mannequins. Mixed reality, on the other hand, is a category that encompasses the combination of virtual reality environments and reality. An example of this would be improving the fidelity of a mannequin-based simulation scenario through the incorporation of an SP to represent a family member. Hybrid simulation is the union of 2 or more modalities of simulation with the aim of providing a more realistic experience. An example of this would be combining the use of an IV arm pad or trainer with an SP so that the skill of initiating IV treatment can be incorporated alongside objectives related to personal skills. Being familiar with the different types of settings available will also help the educator choose the most appropriate setting for each SBE. Having a dedicated simulation space, such as a simulation center or lab, is an incredible resource. The location of the program can also influence learner accessibility and the educational content. Consider the different impacts of simulation centers located within the health sciences building on a college campus versus within an acute care facility or as an independent center centrally located within a community. When choosing a new location or reconfiguring an existing space, keep program objectives and goals in mind. BioSkills describes the practice of simulating a medical environment for the education of healthcare professionals for the purpose of teaching, studying, training, or researching the gross structure of the human body or performing medical or surgical procedures. BioSkills replicate the patient experience through the use of human or animal anatomical specimens like cadavers, either whole or in part, medical simulators, or synthetic models. BioSkills includes activities such as dissection, removal of or carrying out of a procedure on or in relation to one or more parts of the body, placing into the body any part of a body, prosthesis, or implant. Healthcare professionals practice procedures in a BioSkills lab to learn a new skill or to improve their current skills proficiency prior to conducting the same procedure on a live human or animal. Mobile simulation refers to simulation-based learning events that are conducted utilizing portable equipment. These resources are usually employed to bring experiences to learners that may have limited access to healthcare simulation. Mobile simulation setups can range in complexity from portable simulators being transported to a skilled nursing facility for something like annual validations, to tractor trailers outfitted to resemble actual patient care areas. This simulation setting fits very neatly within the adult learning theory paradigm, but it can have limitations, especially regarding insurance requirements, specific driving credentials, storage of the vehicle, and or its maintenance when it's not in use. In situ, or in situ, means in the original space, and it was originally coined as an anthropologic or archaeologic term. This simulation setting allows for education that incorporates the actual medical equipment and staff resources that team members utilize daily, and it can help to address multiple different IPE needs. Workflows, systems testing, and the evaluation of new processes are easily replicated, and even rigorous appraisal of new spaces can be completed in the actual environment. In situ simulations can yield impactful information, but they also have increased safety and operational concerns. When you're entering the clinical environment with a simulated event, safety standards must be created to address not only the physical and psychological safety of the learners, but also of the patients, visitors, and any non-participating staff. It is critical to have a plan and to make it part of a standardized procedure. Questions to consider include, how will unit staffing be impacted? Will the equipment diverted for training delay real patient care? If real emergencies occur at the same time as your event, how will that be handled? If practice medications will be used, what standards exist to prevent them from entering patient flow? How will this event affect the simulation program staffing? How will gear be transported? And will hours of operation need to be adjusted to accommodate the in situ setting? Learner engagement in simulation-based education. Now that we understand some of the resources available to educators during SBE, let's discuss factors that impact learner engagement. Realism and fidelity can go hand in hand, as they represent similar concepts focused on different dimensions of engagement. Realism is the ability to impart the suspension of disbelief to the learner by creating an environment that mimics that of the learner's work environment. And it refers to the physical, semantical, and/or the phenomenal aspects of the activity. Fidelity is the ability of the simulation to reproduce the reactions, interactions, and responses of the real-world counterpart. Fidelity can involve a variety of different dimensions, including physical factors such as the environment, equipment, and related tools, psychological factors such as emotions and beliefs and the self-awareness of participants, social factors such as participant and instructor motivation and goals, the culture of the group, the degree of openness and trust within that group, as well as participants' modes of thinking. As mentioned previously, it is not constrained to a certain type of simulation modality, and higher levels of technological fidelity are not required for a simulation to be successful. Miller points out that what a person does is built upon the knowledge, competence, and performance. The higher the experiential fidelity, the more a student does, and therefore the more opportunities there are for learning. When considering physical fidelity, in situ experiences usually represent the highest level of physical realism. This isn't to say that SBEs occurring outside the clinical environment can't be realistic, however, and choosing the correct simulation modality for the event is equally important. Some ways to improve physical fidelity would be to access the EHR training platform for physical assessment scenarios, or using refurbished hospital beds and ventilators during critical care scenarios. These approaches help participants engage in the SPE. From a psychological perspective, the utilization of a standardized pre-brief will explain the learning contract, set parameters for the simulation, and establish learner psychological safety. If the users know what to expect and they feel at ease, they can go about the business of exploring the situation and learning from the experience better. Some ways to use sensory feedback to increase the psychological fidelity could include adding the smell of smoke to a room being staged to treat a victim of full-thickness thermal injuries, or placing coffee grounds in the simulated emesis of a patient enduring a GI bleed. Conceptual fidelity ensures that all the elements of the scenario relate to each other in a realistic way, so that the case makes sense as a whole to the learners. As such, content experts should always vet cases, and simulation teams are expected to pilot scenarios being utilized for the first time or those being utilized for the first time with a new user group. These quality assurance measures help to promote conceptual fidelity. They can include considerations like, does the scenario actually make sense at a physiological level? Does that ECG really look like VFib? Do the vital signs truly reflect hypovolemia? Or does the patient's acuity accurately reflect the environment's level of care? Functional fidelity is the degree in which the equipment used during the simulation responds to the participant's actions. Using a static ventilator, for example, would offer very low functional fidelity compared to using a working ventilator, especially if your simulation scenario requires a ventilator alarm. Okay, so now we have created an event, selected educational modalities, chosen the setting, and all while keeping realism and fidelity in mind. Now we need to focus on facilitation. As evidenced by this slide, facilitation applies to each and every component of the simulation, not just the debrief. It's not enough to simply design a simulation activity and then to expect any group of learners to function well. Care has to be taken to identify the level of the learner in order to design an activity that challenges but doesn't overwhelm, since we all know that overwhelmed learners are less likely to engage and also less likely to take risks. The second stage of Kern's curricular development involves a targeted needs assessment, where the level of the learner is identified. Being cognizant of this allows for the development of relevant learning objectives and also the creation of a really meaningful simulation activity. Principles of adult learning come into play as well, since learners will bring their prior experience to the simulation activity, be it clinical or educational, or even just real-life experience. A well-thought-out simulation activity allows learners to build on prior knowledge and to reinforce important concepts. IPE or in situ simulation experiences may include participants of different experiential levels. The simulation activity really needs to be designed to be relevant to all of these various levels of learning. Similarly, the debriefing itself will need to be facilitated such that it meets the learning needs of all the participants. As noted in defining excellence, simulation environments should be safe places to learn and make mistakes. Some stress is good, heightening awareness of the situation and making an impact on the learner, so that if they experience a similar situation, they can act effectively and efficiently. At the same time, it's imperative that learners are not placed in situations where the level of stress is too high and it impacts their cognitive abilities in a negative way. We know that simulations are stressful to learners. Learners experience physiological as well as psychological stress just thinking about having to perform in a simulation, thinking about talking with an SP or being videotaped, and receiving feedback. Learners, especially those in post-licensure peer groups, may feel more exposed and worried that their simulation performance will affect or hinder their relationships at work. This highlights the concept that a fundamental characteristic of simulation-based learning is the establishment of psychological safety. As simulation educators, we can't control any individual's worry over their actions during a simulation, so it's important that we manage the balance between good stress and cognitive overload. Some ways to achieve this would be by planning experiences without excessive objectives, multiple distractors, or unfamiliar equipment, designing scenarios appropriate for the learner's level of clinical experience and their previous simulation exposure, and using the pre-brief to explain the facilitator's intent, to outline learner expectations, and to reiterate the concept of respect in communication standards for everyone participating. Suspension of disbelief is the concept that for learners to become involved with the simulated clinical experience, they must react as if the patients and families are real and be willing to accept or go along with some unrealistic aspects of the event to fully participate in and learn from the event. This is the intention to accept a mediated content as real and to suppress external stimuli and internal cognition that might contradict the illusion of the experience. Suspension of disbelief helps one to resist doubts about the simulation's authenticity. Facilitating learner connections in simulation-based education. Now that you have your scenario created and have begun anticipating for learner engagement, let's consider feedback. Giving feedback is the process of providing learners constructive information to help them reflect on their performance by identifying areas of strength as well as opportunities for improvement. Traditionally, feedback had been noted as a unidirectional communication about a recipient's behavior. Feedback sessions are more powerful when participants can reflect on their knowledge, skills, and attitudes and self-identify opportunities for improvement rather than receive that information wholly from their instructor or supervisor. Components of effective feedback include timely appraisal of observed behaviors that are focused on changeable behaviors or attainable goals. Effective feedback reinforces desirable behaviors while helping individuals and teams identify how to improve their performance. Debriefing is a form of feedback. The Healthcare Simulation Dictionary states that best practices include conducting a session immediately after a simulation event, providing an opportunity for facilitators and learners to re-examine the simulation experience in order to move toward assimilation and accommodation of learning to future situations, encouraging participants reflective thinking, and providing feedback about their performance, while various aspects of the completed simulation are discussed. Exploring participants' emotions, and supporting participants to question, reflect, and provide feedback to one another. Debriefing approaches should be based on a feedback framework so that they are organized enough to keep learners on track, but organic enough to let them direct the discussion while still covering objectives and critical concepts. A typical debriefing should encompass 3 phases. The first phase of the debriefing is the reactions phase. During this phase, participants are invited to share their emotional responses to the simulation. This allows participants to clear their chest and subsequently focus more deeply on the remaining phases of the debriefing. The second phase of the debriefing is the analysis phase. In this phase, participants are encouraged to reflect on and discuss their thinking and actions during the simulation. The last phase of the debriefing is the summary phase. During this phase, the main learning points from the debriefing are summarized. According to Lobriato, to debrief is to encourage participants' reflective thinking and provide feedback about their performance while various aspects of the completed simulation are discussed. To highlight this concept, recall how Kolb's experiential learning theory uses a circular model that represents a cycle of learning with 4 components. The first is the concrete experience, where learners have an experience or are doing or actively engaged in the experience. Next is the reflective observation, where learners review or reflect on the experience. This is followed by an abstract conceptualization, where learners learn or conclude what was learned from the experience. And finally, there's an active experimentation, where learners plan to use the gained knowledge and skills and try out what was learned from the experience. Guided reflection is a process by which facilitators encourage learners to explore the critical elements of an experience in an effort to gain understanding and insight. Being an intellectual and effective activity, it promotes the linkage of theory with practice and research. It can be integrated into a debriefing or be accomplished through an exercise following the SBE event, such as journaling and/or open discussions. Stages and skills of reflection may include being open-minded, identifying existing knowledge and challenging assumptions, integrating new knowledge into practice, or supporting existing knowledge. Here we take a deeper dive into ways of categorizing reflection during debriefing. On the previous slide, we discussed reflective thinking in general, as it might be represented by a learner experiencing an event, identifying knowledge gaps, and determining ways to improve performance. Reflection in action refers to the insight that is gained during the actual activity, as in through the use of deliberate practice. Reflection on action, however, is a retrospective process, such as the learning that would take place during the debriefing or during reflective journaling. Making improvements by utilizing simulation-based education. Remember all the way back to the beginning of Domain 2, when we were discussing all the areas in which simulation-based education can impact learners? Well, here's a key. The learners are not the only ones that can be impacted. Insights that are gained, observations that are made, and surveys that are completed during these experiences can be used to make changes to the system and ultimately patient and educational outcomes. The value of using healthcare simulation for system evaluation is really limitless if you consider its ability to assess the multiple dimensions of healthcare without the potential of harming any individual patient care. System integration events look at the processes, teams, and human factors associated with all the people, disciplines, procedures, guidelines, healthcare standards, departments, and equipment utilized in actual patient care. The term human factors categorizes interactions at the human to system interface, with a focus on improving efficiency, productivity, creativity, and job performance while eliminating errors. The term addresses biomedical and psychological considerations and incorporates principles and applications from the perspectives of engineering, personal selection, training, life support, job aids, and human performance evaluation. Think about a defibrillator. Note that over the last several years, all brands now have numbers on the faceplate of the equipment that promote accurate discharge of energy during an emergent situation. Consider why ergonomic engineers chose that equipment cover and how educators will incorporate the markings into their staff education. Additionally, consider how repetitive use in a safe environment with this specifically designed piece of equipment can create confidence and competence and translate to shorter times to defibrillation in the actual clinical area, and thus improve patient outcomes. By applying the same standards of psychologically safe learning, participants will fully engage, knowing that they can make mistakes without consequences. The clinical environment can then be fully assessed for safety, physical resources, equipment, as well as processes and procedures. By taking the information gathered about knowledge and process gaps uncovered during the events, and then applying them to elevate clinical practice and patient care globally, this is how well-designed simulation events can improve patient outcomes. As we reflect on best practices for designing effective simulation curricula, we might relate these to an hourglass approach, where the theories and didactics being presented start big, but get smaller and more personal as the learner is better able to interact with the concepts during simulation-based experiences, and then finally become big again as they incorporate these standards into personal practice with the ultimate impact on patient care. Again, the goal is to take what we have learned and use it to support the content that is needed, as well as how that content is facilitated in order to improve educational systems and assessments.